All right. So this is I'm Dr. Erik Escuro. This is my second echo lecture. Last month, I believe, or 2 months ago, we did a lecture on gout. And today's lecture is going to be on rheumatoid arthritis. So I'm one of the assistant professors here at WVU Rheumatology. I'm involved with the Rheumatology Fellowship as the associate program director. And not born and raised West Virginia, but my wife is from Beckley, and we moved back here last year, and we're really excited to be back. So rheumatoid arthritis, one of our more common inflammatory arthritis diseases, not the most common, but one that I think a lot of us are at least familiar with. And today's lecture hopefully will be addressing not only getting the skills to recognize when it's rheumatoid arthritis, or at least increase suspicion, but more so in terms of obtaining appropriate workup at the beginning, and then obviously finding out when you should be referring to rheumatology, but also covering some potential treatment options that could be done even before patients reach rheumatology. So objectives today, as I mentioned, we're going to be covering some of the basics of RA, including epidemiology, pathophys, risk factors, how we go ahead and make an accurate diagnosis of rheumatoid arthritis. When rheumatoid arthritis goes beyond the arthritis component and ends up involving other organs, management, and then we'll briefly cover some special populations, including pregnancy and rheumatoid arthritis. So whenever we think of arthritis, I bring this up constantly with my patients. If I said arthritis, I think the vast majority of us would think of osteoarthritis. My father, he just retired from being an oncologist. And even if I told him, Dad, I think you have arthritis in your knee, he would still think that we were talking about bone on bone arthritis. But inflammatory arthritis covers a lot of the things that we cover here in rheumatology. As I said before, we covered gout a couple of weeks ago, but rheumatoid arthritis is one of our more common inflammatory arthritis diseases as well. And so when we think about a normal joint versus the wear and tear joint of OA versus the inflammatory arthritis joint of rheumatoid arthritis, it's not so much that joint space narrowing issue as you see in that middle image of osteoarthritis. In fact, oftentimes in rheumatoid arthritis, the joint spaces are well maintained. Instead, it's an issue of the synovial capsule, the joint capsule, and the synovial membrane. And so, unfortunately, the issue ends up being that your immune system sort of loses its ability to self-regulate or recognize itself, and it starts attacking parts of your body that it should not be attacking. And we'll go over what that means in terms of workup in a bit. So if I showed a picture of these hands, I call this the grocery store sign. And I always tell patients and my fellows that that's not a real thing. Grocery store sign isn't something that they teach in textbooks or in lectures. Instead, it's something that I think about when I think if I'm at the grocery store and somebody's paying and I see these joint deformities on the hands, would I be able to tell without even talking to the patient that they have one type of arthritis versus another? So my grocery store sign here is mainly at the DIPs, or basically the joints, the small joints that are nearby the fingernails. And those are what we call Heberden or Heberden nodules. And that's just from significant wear and tear over the years. If you think of things like bone spurs, basically, that's what you're seeing there with those firm nodules. Now, the image on the right, you have similar deformities at the PIPs, or those middle joints of the fingers. And these joints are again, mainly wear and tear changes. And if you pressed on those joints, they would be very firm, not squishy or boggy like you would expect in an inflammatory arthritis. This is in stark contrast to rheumatoid arthritis. Rheumatoid arthritis is a disease that is quite deforming. And you'll notice that the fingers themselves, like if you take a look at the right hand on your left, at the pointer finger, that finger looks pretty straight. There aren't very big nodules that are on the PIPs or the DIPs, but clearly there's a deformity at the MCPs with a drift off to the side, what appears to be swelling at the big knuckles, the MCPs, when in fact, all you're seeing there is that the fingers themselves have dropped down from the deformities, and you're actually just seeing the head of the metacarpal. And so this is obviously what we're trying to avoid in rheumatoid arthritis. It is not surprising when patients with these types of deformities actually tell us that they're not in any pain. And the reason being is that the damage has been done and there's nothing really to get inflamed anymore. But the unfortunate part is that the patient can no longer use their hands. And so when it comes to rheumatoid arthritis, we always go back to this Venn diagram of history, physical exam, and then the diagnostic workup. And in a perfect world, everything would always overlap in a perfect way where the story makes sense, the physical exam makes sense, and then the labs and imaging support that diagnosis. But in real world medicine, we're not always so lucky. Sometimes the labs or the imaging don't clearly show or suggest rheumatoid arthritis, but based off of taking a thorough history and doing a good physical exam, you're convinced that they have RA. And so that's what makes rheumatoid arthritis and honestly a lot of rheumatologic diseases a little bit different than some of our other conditions in internal medicine, in that you can't go off of just one lab or one feature because there's a lot of mimickers, and sometimes these labs are negative when in fact you do have the disease, and sometimes the labs suggest RA and you don't have RA, and it's due to something else like an infection or a malignancy. So we always aim for that overlap of all three. If there's only an overlap of two, meaning history and exam are there, but the labs don't support it, maybe the exam and the labs support it, but the history doesn't necessarily make sense, we can still call it something like rheumatoid arthritis. It's those situations when you're relying on just one of these circles, like just the story or just the lab or just the exam, where you have to reconsider that maybe that we are off base with our evaluations. So rheumatoid arthritis, it's an inflammatory systemic, not just located in the joints, but it's a systemic autoimmune condition. It typically presents as a symmetric inflammatory polyarthritis. So multiple joints, five or more, mirrored across the left and the right side. And that's your typical presentation of rheumatoid arthritis. Again, there can be atypical cases. Classic joints involved include the small joints of the hand. So we call these the MCPs, the big knuckles, the PIPs right in the middle of the hands, and then also involvement in things like the feet and the wrists. That doesn't mean that it can't affect other areas like the neck or the elbows or the knees, but these are the more common areas. Rheumatoid arthritis, unfortunately, can be associated with several extra-articular manifestations that we'll cover today. And when we're looking at the epidemiology of the disease, it isn't as common as something like osteoarthritis. It only affects 1% of the population, but it does have some favoring of female patients, with women being affected 2 to 3 times more than men. It can affect patients of any age, but the peak incidence does appear to be around 30 to 60 years. Sometimes patients just don't have access to rheumatology, and they've been suffering with RA for a while, but they don't get diagnosed until they're 70 or their 80s. That can occur. And I have plenty of patients who are diagnosed in their late teens or their early 20s. Now, the healthcare cost associated with rheumatoid arthritis is extremely large, and that's not just from untreated disease, but it's also the treatment of the biologics that oftentimes we have to turn to control the disease. And unfortunately, given the ongoing inflammation of this condition and its extra-articular manifestations, unfortunately, it can reduce average patient's lifespan by quite a few number of years. Now, we don't necessarily understand completely how rheumatoid arthritis ends up becoming active or who it's going to affect, but we do have some suspicions. We view that there is some sort of genetic factor involved in the development of rheumatoid arthritis. So it's not surprising when somebody with full-blown RA has a family history of rheumatoid arthritis, or if they say something along the lines of, my siblings had it, my grandparents had it. Now, that doesn't necessarily guarantee that they're going to have rheumatoid arthritis, but we do pay attention to that. In terms of studies that looked at siblings of affected patients, we found that there's at least 2 times the risk compared to patients that are, unrelated, of developing rheumatoid arthritis, and that even more so in the offspring of affected patients. In twin studies, it showed that with the high sharing of rheumatoid arthritis across twins, that there is likely some sort of genetic factor, although we haven't necessarily identified a specific gene that is at cause here. Instead, we end up relying more on certain proteins and certain antibodies that are present in the blood. When it comes to the autoantibodies, in terms of the labs that we oftentimes rely on to at least screen for rheumatoid arthritis, but to also confirm the disease, we rely on two. One is called the rheumatoid factor, and the other is called the anti-cyclic citrullonated peptide, or anti-CCP antibody. Sometimes you'll see that referred to as ACPA, ACPA. These are oftentimes present in the blood. They can sometimes be present in the synovial fluid, but unlike gout, where we talked about getting a fluid sample and testing for monosodium urate crystals, we don't really rely on aspirating joints in this setting and looking for rheumatoid factors or anything like that. These autoantibodies can oftentimes be present in patients before you end up having any clinical symptoms, which raises the question of whether we should be treating those patients even before they do have joint symptoms, but I'll get into that in a little bit as well. And unfortunately, these rheumatoid factors in CCPs are oftentimes not sufficient for diagnosing RA, as we discussed earlier with the Venn diagram. So, what is a rheumatoid factor? So, a rheumatoid factor is just an immunoglobulin, like usually an IgM, that directs or is attached to the Fc portion of IgG. And I'll have a picture of that in a second for you to refer to. The sensitivity is quite high. There's been studies that suggest anywhere from 70 actually to 90% sensitive for rheumatoid factors in rheumatoid arthritis. But the specificity isn't as high as the sensitivity is. When a rheumatoid factor is present, there is an associated increased risk of RA, but especially widespread disease with erosive changes. And the rheumatoid factor, even in the setting of just rheumatology, can be present in several rheumatologic conditions: Sjogren's syndrome, systemic lupus erythematosus, inflammatory myopathies like dermatomyositis and polymyositis, hepatitis-related cryoglobulinemia, and sarcoidosis. As I was mentioning before, the rheumatoid factor most commonly is the picture on the left, an IgM that's directed against the Fc portion of IgG. Sometimes you will come across a test that is an IgG rheumatoid factor. This is the one that we usually do not rely on. If you get your labs through Quest, or if you get it through some sort of panel, like an advice panel, which we'll be discussing in December, those types of workups can sometimes include an IgG, but we're actually not as certain about the utility of that type of rheumatoid factor compared to the IgM. Most of the historical studies have been referring to the IgM rheumatoid factors. And actually referring to our own system here at WVU, you actually cannot specifically order an IgG rheumatoid factor. All the rheumatoid factors that we order here are IgMs. Then there's the anti-CCP antibody. The anti-CCP antibody is much more specific for rheumatoid arthritis, but might not be as sensitive. And this type of lab doesn't have as much of a crossover with other conditions. For instance, you don't find it in cases of lupus or cryoglobulinemia as often, but it still can be seen in other conditions like chronic smokers. The clinical significance of the anti-CCP antibody is that it has an even greater risk for erosive changes and radiographic progression. So these patients oftentimes end up having a more severe disease course. Now, for the patients where you're quite confident that it's rheumatoid arthritis is when you have both a positive rheumatoid factor and a positive anti-CCP antibody. And in those cases, that's a very high positive predictive value for having true rheumatoid arthritis. Now, when it comes down to what is causing rheumatoid arthritis, as I mentioned before, it hasn't been completely determined, but we do have a suspicion that there is some level of environmental factors that are interacting with some sort of genetic factor. And so we think it's still sort of like multifactorial in that standpoint. And so in patients that have a history of cigarette smoking, we do find an increased incidence of rheumatoid arthritis in these patients, and we feel like it might be due to the increased development of these anti-CCP antibodies. There are some occupational exposures that we feel contribute to rheumatoid arthritis as well, but doesn't necessarily guarantee it. There's been a wide interest in terms of infection causing rheumatoid arthritis. About 13 years ago, it was a pretty hot topic that they thought that a virus like Epstein-Barr virus was causing rheumatoid arthritis. It was the main topic of the plenary sessions at the American College of Rheumatology conferences. Unfortunately, that didn't really pan out, and we haven't found a specific virus or a specific bacteria that is known to cause it. There is a question about some of the oral pathogens that can potentially be linked to generating anti-CCP antibodies, but again, not enough for us to 100% be confident in it. And when we think about certain populations that are more likely to develop rheumatoid arthritis, including female patients, it does bring up the question about whether sex hormones are involved in the modulation of this disease as well. So, how do we go about diagnosing rheumatoid arthritis? So, first of all, if somebody has just a several day or several a week history of inflammatory arthritis, you know that it is an inflamed joint. It is red, it is hot, it is swollen. Those are still not patients that we necessarily suspect have RA because these initial symptoms should be present for weeks, if not months, of joint pain. The number of joints involved should be more than three, more than or greater than three. And oftentimes these are the small joints of the hands and the feet. One area where we frequently drop um, our suspicion for rheumatoid arthritis is if you have significant lower back pain, because for whatever reason, the lower back is oftentimes spared, as are the DIPs of the hands. Sometimes you will have a case where you have just one joint involved. But if there is only one joint involved, there are plenty of other conditions that can just have one joint that's involved with inflammatory arthritis, including gout and psoriatic arthritis. Sometimes you'll have associated constitutional symptoms, weight loss, fevers, and more often things like fatigue and malaise. So the vast majority of rheumatoid arthritis develops as an insidious onset. This is the very typical presentation, meaning that it's developing over the course of weeks or months. But there are some more acute or atypical presentations of the disease as well. For instance, sometimes in the elderly patients or the elderly onset group of patients of RA can pop up in a very fast way. Sometimes you get those days to weeks, but again, the vast majority of these cases develop over weeks to months. And then sometimes you have an atypical presentation. What looks to be carpal tunnel syndrome ends up being rheumatoid arthritis. And it's because of something like swelling in the wrists that ends up causing extrinsic compression of the median nerve. And now it's leading to something like carpal tunnel syndrome when in reality it's coming from an inflammatory arthritis like RA. There are some special cases of rheumatoid arthritis like palindromic rheumatism. These patients can have positive rheumatoid factors, but palindromic rheumatism is very unique in that it goes to one joint for less than 48 hours, and then it jumps to another joint. So it goes from the left knee, it's inflamed. The left knee resolves, but now it's the right wrist. It stays there for 40 hours. Then it jumps to the left elbow. And these patients, as I mentioned, can have positive rheumatoid factors, but again, it's not symmetric and it's not polyarthritis. But these patients, oftentimes, we feel ends up being some sort of version of early rheumatoid arthritis, with a lot of these patients ending up evolving into a symmetric polyarticular disease that's more indicative of typical rheumatoid arthritis. There are patients that oftentimes older male patients with a history of manual labor that have a version called arthritis robustus. And these patients can have a significant onset of this inflammatory arthritis. But the interesting ones are actually the ones who have this version of it that doesn't really hurt all that much. You look at their hands and it looks like straight up rheumatoid arthritis, but they don't have much joint pain. And we call these the blissfully unaware patients, but it is a version of rheumatoid arthritis as well. And then, as I mentioned before, we have several versions of extra-articular manifestations of disease. So this is a picture that I oftentimes refer to and I use to teach our medical students, residents, and fellows that if you had to draw a map of the hand and wrist specifically, the location of the joint pain itself can oftentimes suggest to you what type of arthritis you're dealing with. So in rheumatoid arthritis, the green and the yellow areas there, the MCPs and PIPs, are the typical areas for RA. Whereas for something like osteoarthritis or psoriatic arthritis, it's usually the PIPs and the DIPs. The PIPs I almost, oftentimes consider as like no man's land because a lot of different things can affect the PIPs. The MCPs more specifically can be targets of pseudogout and hemochromatosis, where oftentimes synovial fluid aspiration or radiographic evidence can point you in one direction versus the other. Base of the thumb almost always is osteoarthritis. So the CMC grind test by just putting quite a bit of pressure at the base of the thumb can be very indicative of just osteoarthritis. Whereas the ulnar or the radial side of your wrist, the lateral aspect of the wrist, is oftentimes an overuse injury with de Quervain's tenosynovitis, where you can do that Finkelstein test where you tuck your thumb, lightly grip, and apply pressure downwards. If you have pain up there, that's consistent with the overuse injury of de Quervain's. And then the wrist itself, a frequently involved area of rheumatoid arthritis, but also can be involved in other inflammatory arthritis diseases like pseudogout. Looking at a skeleton in a whole, I think the big picture here is, again, it's a very peripheral disease, small joints of the hands, small joints of the feet, whereas the lower back is a very uninvolved area. The neck, though, can be involved, and unfortunately, with patients with advanced disease, there can be C1, C2 subluxation in that area. So if you have a rheumatoid arthritis patient who is planned to have general anesthesia, we usually get X-rays of the cervical spine to make sure that that is not present, because anesthesiology needs to know that before they intubate. Unfortunately, those patients can have severe complications like paralysis if left unaddressed. So when it comes to the typical presentation, I've mentioned it a couple times now, it's very symmetric disease, MCPs and PIPs being the most involved areas. And in terms of the specific joint deformities, these are usually later on in the course of the disease. But you have what we call the ulnar deviation or ulnar drift, where at the MCPs you have the drift of the fingers. The fingers themselves can look straight, but they go off axis at the MCPs themselves. If you think back to that, those other pictures where it looks like there's a lot of swelling at that MCP, and you're just looking at the metacarpal head. At that second picture, that's a picture of that partial dislocation or that knuckle subluxation or MCP subluxation that you're seeing. And that's that rounding out that you're seeing at the MCPs. The same thing can happen at the wrists, where the hand drops down compared to the line that's there from your arm, and that's another deformity that occurs oftentimes with destabilization of the tendons. Swan neck deformities can occur with hyperextension at the PIPs and hyperflexion at the DIPs, and that's the opposite of boutonniere deformities, where you have hyperflexion at the PIPs and hyperextension at the DIPs. Swan neck deformities are much more specific for rheumatoid arthritis, whereas boutonniere deformities can be seen in just trauma. Like if somebody has some sort of knife injury to their hand, you can end up getting a boutonniere deformity. And the final deformity that you see there is the Z-shaped thumb, where basically your thumb goes, juts out basically 90 degrees at the IP there at the interphalangeal joint. And we oftentimes call this the hitchhiker's thumb of rheumatoid arthritis. So when it comes to diagnosis, we were talking about the history, the physical exam, but when it comes to the diagnostic workup, and I think the thing that oftentimes gives you the confidence that these patients need to be sent over to rheumatology, it's when one of the labs are significantly abnormal. So the rheumatoid factor, the CCP antibody, but we always encourage to get inflammatory markers as well, both the SED rate and the CRP. Because if there's an unexplained and elevated inflammatory marker in the right clinical setting, like an inflammatory arthritis, then that will increase our suspicion for RA oftentimes. But again, these antibodies are not specific enough to establish a diagnosis in isolation. Oftentimes, these patients can have other findings of chronic inflammation, like a normocytic anemia, like a MCV between 80 and 90 or 80 and 100. Thrombocytosis, so if your platelet count is just a tad high and you're not sure why, that might be from chronic inflammation. But then you also have to keep in mind that there might be other symptoms as well that are suggestive of other diseases, like lupus, Sjogren's syndrome, or if they have a history of hepatitis B and hepatitis C, those markers may be abnormal as well. In terms of imaging, we always suggest that getting baseline radiographs or baseline films of both the left and the right side, even if the joint pain is just on one side, is very helpful, because what we can look for are some subtle findings of an inflammatory arthritis, like some soft tissue swelling. But really what we're looking for are those periarticular erosions. And I'll show you an example of those in a bit here. There are other more advanced imaging studies like musculoskeletal ultrasound that is more of like a dynamic study. So it can show active or ongoing inflammation. Whereas other imaging studies like MRI can sometimes show you some subtle areas of erosions that you might not have picked up on an X-ray. So here's an example of normal hands, left and right. And things that I would say are normal here are that they look pretty, for lack of a better word. You have a nice rounded out MCP joints, PIPs and DIPs. There's no presence of erosions. The bone density is pretty equal throughout all of these, throughout all the long joints of the long bones of the fingers and the hand, as well as around the joints themselves. But by comparison, you have the plain radiographs of a rheumatoid arthritis patient. And we'll focus in on a couple of these joints in a second, but there are clear findings of erosions at the margins of these joints. That darkness that you see around the MCPs are what we call periarticular osteopenia, which is another oftentimes appreciated abnormality of X-rays in rheumatoid arthritis. And as I mentioned before, these erosions occur at the margin. So if you take a look at the joint on the left, that's a pretty normal uh, PIP example of a joint. Whereas if you compare it to the right joint, the joint up furthest to the right, you have that defect on the side of the PIP joint there. And this is what we call an erosion. When I explain it to patients, I oftentimes refer to if they used like a pressure washer on concrete. Like if you put a pressure washer on concrete for just a couple of seconds, you clean the concrete. You keep the pressure washer on concrete for too long, like minutes or hours, days, years, you're going to erode that concrete. And the difference in these erosions compared to the gout erosions from our last lecture are that these look a little bit more fuzzy at the edges, like they're not as clean cut as some of the gout erosions that we had referred to previously. And oftentimes the location of the erosion can be very helpful as well, because if the erosion is at the MCPs or the PIPs, then that's probably going to be an RA erosion. Whereas if you have a clean cut erosion or a rat bite erosion at your first MTP, that's likely going to be gout. Ultrasound is a very useful study when available. When I was in Myrtle Beach, I am not ultrasound certified, but when I was in Myrtle Beach, I did not have easy access to ultrasound. Whereas here at WVU, Dr. Kasim and Dr. Nair, two of our colleagues here at WVU Rheumatology, they are certified in ultrasound. So oftentimes I'll send those gray zone area, those gray zone patients that I have where I'm not entirely convinced they have RA, and the X-rays don't give me clear evidence of RA. I'll oftentimes send them to my colleagues and they'll just put an ultrasound probe on it. They'll go through all the joints and they'll look for areas of increased Doppler signal, suggestive of an ongoing inflammatory arthritis. You can also sometimes find early erosions or even more subtle findings like chronic synovial hypertrophy that you wouldn't have otherwise appreciated on an X-ray. If there is a red hot swollen joint, as we mentioned in the gout lecture, we always try, if it's big enough, like a knee or a wrist, taking fluid out to make sure that it's not an infection. Usually the cell count in these patients will be below 50,000, but negative cultures, negative crystals are very, more suggestive of inflammatory arthritis like rheumatoid arthritis or psoriatic arthritis. When it comes to extra-articular manifestations of disease, I won't go too far into these because this could be a lecture in and of itself. You can have these things called subcutaneous nodules or rheumatoid nodules. Sometimes they're difficult to tell the difference when compared to gout, but I'll show you examples of both. Sometimes these patients can have, like on a hematologic end, as I mentioned before, a normocytic anemia. Felty syndrome is a very interesting manifestation or presentation of rheumatoid arthritis where you have this triad of rheumatoid arthritis, splenomegaly, and leukopenia, specifically a neutropenia. But I actually had a very difficult patient lately where he had a very enlarged spleen. He had a very low white blood cell count. Hematology did a bone marrow biopsy on him. They did not find anything like a myelodysplastic syndrome or any other type of blood malignancy. And they said, we're pretty sure that this is Felty syndrome. The thing is, we don't have a way to confirm that. It's a lot of clinical suspicion. And so my patient that I had, he ended up having to be admitted to the hospital because his absolute neutrophil count was below 500 and he was having fevers. We found out that he had findings of cholecystitis, as well as an associated abscess that appeared to be around the gallbladder. They put in a cholecystostomy tube with no prednisone, no escalation of his RA meds, and wouldn't you know it, his spleen got smaller and his white counts improved. And so if we had treated this as rheumatoid arthritis with him already having been on TNF inhibitors, high doses of prednisone, the next treatment would have been rituximab. And to think of giving somebody rituximab when they have an infection is something that keeps a rheumatologist up at night. And so I'm glad that I dragged my feet just long enough for IR to put that cholecystostomy tube in, and you just saw those white counts go right back up to normal. So here's an example of rheumatoid nodules. They can be present oftentimes at the hands, the ankles, the elbows. And if you took a look at those nodules, you might think back to our gout lecture and be like, doesn't that look a little bit like a tophus? Now, the difference there being is that the tophi usually have that chalky appearance, like it's trying to come out of the skin. But sometimes they look very much alike. Sometimes an aspiration of that nodule could show, clear monosodium urate crystals where you're very reassured that it is a gout nodule like a tophus. Sometimes in X-ray you'll have more calcification when it comes to the gout-related tophus as well. But oftentimes it's hard to tell the difference between the two. The lungs and the heart are two common areas for extraarticular manifestations. We can have the presence of an exudative of pleural effusion, oftentimes trying to tell the difference between malignancy versus something like a rheumatoid arthritis pleural effusion. There can be pulmonary nodules, especially if there's the presence of rheumatoid nodules on the hands or the elbows. Kaplan syndrome is one that is actually more common in this area because of some of the exposures that we have in our population, as well as these pulmonary nodules. Interstitial lung disease, oftentimes a UIP pattern, but it can be other patterns like NSIP. We oftentimes work alongside our pulmonary colleagues to co-manage these patients because there are certain biologics that should be used for those patients. And sometimes it's actually the medication that leads to pulmonary issues. So, for instance, methotrexate can actually cause methotrexate lung injury and methotrexate nodules within the lungs. When it comes to the heart, recurrent pericarditis can oftentimes occur, myocarditis less so, and we find that there's an increased risk for coronary artery disease in patients with rheumatoid arthritis, likely due to the chronic inflammatory state. We work alongside our ophthalmology colleagues because sometimes our patients can have things like episcleritis, scleritis, and uveitis. There can be some neurologic symptoms, including peripheral neuropathies, mononeuritis multiplex, rarely some CNS involvement. We can sometimes see an inflammatory myopathy that's mimicking polymyositis or dermatomyositis. Kidneys, less so. It's oftentimes more so with the medications, but you can rarely get a membranous glomerulonephritis. Amyloidosis has some rare associations as well as rare vasculitis that can be present. And so we'll shift gears a little bit in terms of discussing the therapeutics. And I really like this image that was published back in 2017 in a Nature Review article, which just goes to show, where we have come, how far we've come in terms of the treatment of rheumatoid arthritis. And you might have some patients where they talk about, like back in the day, they were being treated with gold salts, very toxic medication, but it's all that they had back then. And it wasn't until the 1950s when we truly were able to discover prednisone, which back then they didn't know how much was a good dose, and there was a lot of toxicity associated with it. Hydroxychloroquine in the 1950s was discovered after we were using antimalarials in World War II as malaria prophylaxis, and people's joint symptoms started to improve. Methotrexate really didn't come into play until the 1980s, which interestingly enough, there was actually a publication back in the 1950s suggesting that methotrexate would be useful in treatment of rheumatoid arthritis. But everybody was focused on prednisone at the time. They got Time, the cover of Time magazine, they got the Nobel Prize for it. But ultimately, methotrexate, we didn't find out until years later. We revisited it, and it has now become a cornerstone of our treatment. But in the late 1990s is when we really turned the page here and had some medications that really changed the game for rheumatoid arthritis management. And that's with the development of what we call biologic DMARDs. So sorry, everything that I mentioned so far is what we can call a conventional synthetic DMARD, and these blue medications are our biologic DMARDs. And so the TNF inhibitors were first with etanercept, or what we call Enbrel, infliximab, what we call Remicade. Those were available in the late 90s, early 2000s. And from there, we got our more common medications like adalimumab or Humira. Anakinra, or what we call Kineret, not as good at rheumatoid arthritis, but we use it in certain circumstances, like with recurrent pericarditis. And more recently, our orange medications towards the right there are what we call our targeted synthetic DMARDs or our small molecule inhibitors. These are, for instance, medications like tofacitinib, what we call Xeljanz. What's been approved since 2017 is upadacitinib, also called Rinvoq. So when it comes to our treatments, we now have a variety of medications. Unfortunately, we don't have a lot of head-to-head data. So to say when to use a TNF inhibitor versus an IL-6 inhibitor, we don't really have a lot of superiority studies that convince us to go with one way or another. But instead, what we do is we oftentimes go with experience. So TNF inhibitors have been out the longest. So if we are reaching for a biologic after starting with a DMARD like methotrexate that has failed, we'll oftentimes go to a TNF inhibitor first, and oftentimes insurance companies will require it too. But when we're getting into things like IL-6 inhibitors, JAK inhibitors, CTLA-4 inhibitors, and anti-CD20 inhibitors or anti-CD20 treatments, oftentimes we're looking at comorbidities. So for instance, we don't like using IL-6 inhibitors for people who have had a GI perforation in the past. We don't like using JAK inhibitors in patients who have had a history of cardiovascular disease or blood clots. We don't like using CTLA-4 inhibitors for patients with a history of COPD. And so oftentimes we end up basing the choice of the treatment based off of the other medical conditions. In 2021, we had updated treatment guidelines from the American College of Rheumatology. And much like with gout, we do a treat to target type of treatment algorithm, where basically what we're doing is we're starting off low and then we're only adding on medications if only absolutely necessary or if there's the presence of a certain extra-articular manifestation. So the cornerstone of treatment is methotrexate, especially for moderate or severe disease. If you have somebody with more mild disease, you can get away with hydroxychloroquine. And one of the other takeaways from the treatment guidelines are to have cautious use of glucocorticoids like prednisone, because it does add up with time. And so for most patients, if there is not a contraindication to the use of methotrexate, for instance, active pregnancy or breastfeeding, or a recent malignancy or something along those lines, we'll usually start off with methotrexate and only combine with glucocorticoids as needed. We'll then give it about 3 months. If it's not working in a week or two, we don't say that the medication has failed. We give it about 3 months before we go and add a different medication or switch to another medication. If the patient has reached sustained remission, then we just stick with our dose and we can consider a dose reduction in the future. Now, if for whatever reason there is a lack of control with methotrexate and there are no poor prognostic factors, then you can look in adding a different conventional synthetic DMARD like sulfasalazine, leflunomide, hydroxychloroquine. And data has shown that if you use 3 of them, like hydroxychloroquine, sulfasalazine, and methotrexate at the same time, that you get a pretty similar response that you would get out of something like a TNF inhibitor, like Humira, at a fraction of the cost. But if there are poor prognostic factors, like high levels of rheumatoid factors and anti-CCP antibodies, early joint damage noticed on x-rays of the bilateral hands, or if you've already tried 2 conventional synthetic DMARDs and you're still not going anywhere, then switching to a biologic therapy is the way to go. Now, this is a little bit of an outdated slide because given some of the more recent black box warnings of our JAK inhibitors, we can actually not use a JAK inhibitor until you've failed a TNF inhibitor. So we give it another 3 months and we hope that we get remission with our new combination of treatments. And if not, we continue to add on medications. And if that first TNF inhibitor has failed, we keep cycling through them until we find one that works. One TNF inhibitor that works for one patient may not be useful in another patient. Some patients respond beautifully to TNF inhibitors, others don't, and require something like a JAK inhibitor. But thankfully, we have enough biologics and JAK inhibitors available now that we are usually able to find an effective treatment for most patients. And when patients aren't responding, we oftentimes reconsider the original diagnosis. So what can you do in your clinics? What types of medications could be an option for you to start without even seeing a rheumatologist yet? I say that your safest option is hydroxychloroquine. It does not require any baseline labs like hepatitis B or C studies. Hydroxychloroquine is available pretty much in just one dose, 200 milligram tabs. But we say you should stay below 5 milligrams per kilogram because there is a risk of hydroxychloroquine-induced retinopathy. Now, that retinopathy is not going to kick in until like year 10, assuming that you are staying on a dose below 5 milligrams per kilogram. Usually, our patients will get a baseline eye exam, they'll repeat it at year 5, and they get annual eye exams thereafter. Now, I consider this personally as one of the safest medications in rheumatology. It's a safe medication, but it's a slow med. So it can take up to 6 months to truly kick in. If you have somebody with moderate or severe disease, that's way too long. But for somebody with just mild joint pain, but they do have rheumatoid factors and CCPs and their x-rays look okay, hydroxychloroquine is a very reasonable monotherapy for these patients. Unfortunately, there can be medication interactions with other meds like antibiotics, certain anti-epileptics, and antidepressants, and so just keeping in mind the risk of QTC prolongation. And it doesn't mean that it's an absolute contraindication, but you might want to be grabbing some EKGs every 6 months or so. Here was a study done by Dr. Michelle Petrie at Johns Hopkins around 2019. And she showed that, these cases of hydroxychloroquine-induced retinopathy just aren't happening in these patients on the medication for fewer than 5 years, even fewer than 10 years. It's really from 10 years and greater where we end up finding these retinopathy cases. So, a lot of patients will be very concerned about what they read about this toxicity, but we oftentimes counsel them that, hey, listen, this is not going to happen for a decade or so. Methotrexate is a med that I recommend with a little bit more caution. But when I was in Myrtle Beach, because there were so few rheumatologists, we actually had quite a few primary care physicians that were getting started on methotrexate, especially if you have a really high suspicion for RA. A typical physical exam, typical history, rheumatoid factor and CCP antibodies are through the roof. Methotrexate is an option to start on the primary care setting, but you have to do it carefully. You have to screen for hepatitis B and hepatitis C beforehand, making sure that you get a hepatitis B surface antigen and a hepatitis B core antibody along with hepatitis C screening beforehand. Because for patients with untreated, even, just chronic hepatitis B, chronic hepatitis C, you could go into overt liver failure by adding on methotrexate. And we also get baseline CBCs with a serum creatinine, AST, and ALT. If you start methotrexate, repeat studies should be done about 1 month later, and then you can start testing those labs every 3 months thereafter. I usually just toss in standing lab orders. The starting dose of methotrexate is usually quite low at 7.5 to 10 milligrams a week. But then by weeks 4 to 6, we usually aim for a dose of 15 milligrams. Now, methotrexate comes as 2.5 milligram tabs. And this is the thing that scares me sometimes when I let go of the steering wheel a little bit and I let other people prescribe methotrexate. The most common misconception about this is that it's supposed to be a daily med. No, it is a weekly med. So the way I describe it to patients is methotrexate Mondays. It doesn't have to be a Monday. It could be a Saturday. It could be a Wednesday. Methotrexate Mondays. And it really only comes in these 2.5 milligram tabs. So to get to 7.5 milligrams, you need to use 3 of them. So there's a lot of education that's required there. But oftentimes with experience, that gets a lot easier. And I have some resources that I'll share with you in a second that makes it easier for patients to understand as well. These patients that are on methotrexate, methotrexate inhibits this enzyme that's required for folic acid creation. It's not the folic acid that's the problem, it's just the enzyme itself. And so when you inhibit that enzyme, your folic acid level plummets. So you actually have to supplement folic acid, usually 1 milligram a day, and sometimes up to 5 milligrams a day, to prevent certain side effects such as stomatitis, like oral ulcers, nasal ulcers, hair thinning, and hair loss. A lot of those things can be avoided with regular folic acid supplementation, as well as the macrocytic anemia. Methotrexate is a very toxic medication when it comes to your liver. And so for patients who already have baseline transaminitis, we avoid it. For patients who frequently drink alcohol and cannot come off their alcohol, we avoid it. And then we also reconsider it in patients that are at risk for pregnancy or are currently pregnant, because it has toxicity for a developing fetus. So you just have to be very careful with the use of methotrexate in women of childbearing age. I already mentioned some of our common toxicities. Some of the ones, like the more constitutional symptoms, like a feeling of malaise and fatigue, that's usually only felt the day after you use methotrexate. Here are some of the more intense methotrexate toxicities, including hepatotoxicity, pulmonary toxicity. Sometimes patients can develop those skin lesions that you see on that person's calf, which is a more typical finding of cutaneous manifestations of methotrexate toxicity. And there is a risk of lymphoproliferative disorders. So, in a patient with a history of that, I oftentimes discuss it with oncology first before I start this medication. So, as I mentioned earlier on, sometimes patients get a rheumatoid factor and a CCP obtained, and it's not because of rheumatoid arthritis. For instance, if you were suspecting lupus and you grabbed there's no joint pain, but you grab these labs anyway, and those are the ones that are positive. Or for patients that request it because their family member has RA and they just want to know if they have it or not, and the labs are positive. So there was this question about should we be treating these patients regardless? If we start these patients in their preclinical years when they don't have joint pain, if we give them a safe medication like hydroxychloroquine, could we prevent the progression to true seropositive rheumatoid arthritis in the future? And unfortunately, the result was a resounding no. And so this study that was done across, it was a very widespread study across the United States, recruited all these patients specifically with that very specific anti-CCP antibody, and they measured whether patients developed after a 3-year period into full-blown rheumatoid arthritis, and there was no difference. Now, we don't know at 5 years or 10 years if there's going to be a difference there, but at least at the 3-year mark, there was no significant difference between the two groups of hydroxychloroquine or placebo. So we do not recommend the use of hydroxychloroquine to prevent rheumatoid arthritis. And unfortunately, like when we have our lupus talk, similar findings were found when they were looking to see if you could prevent lupus if you just have a positive ANA and you use hydroxychloroquine. So when it comes to resources, rheuminfo.com is a really nice resource. It has these information sheets that are available that I like handing out to my patients that reinforces that methotrexate is a once a week med and you need to take your folic acid. Don't use this if you're pregnant. Reminding patients that they need to avoid alcohol and get regular blood tests. There's a medication interactions with certain sulfa antibiotics like Bactrim that you should not mix those two. And so this is a nice sheet that reminds patients of the things that they need to know. And the other key thing is that if you are sick and you likely need to be on antibiotics, you probably, in your best interest, should come off of your methotrexate. If at least, and this doesn't just apply to methotrexate, this applies to all the other the biologic therapies as well. If your body is trying to fight off an infection, you should probably come off your RA med because the RA med is making it harder for your immune system to do its job. And I think I've touched on a lot of these things already. Methotrexate's avoided in pregnancy. There are certain medications that are safe to use in pregnancy, like hydroxychloroquine and sulfasalazine. There are certain instances where we will continue TNF inhibitors. There is one TNF inhibitor called certolizumab that is FDA approved for use in pregnancy. And then depending on the weeks of gestation, we are careful with our NSAID use. So in the remaining minutes, I would love to hear your feedback about if you have any difficult cases that you're interested in for rheumatoid arthritis. If you are comfortable maybe starting hydroxychloroquine in those patients that are waiting for their rheumatology visit, or if you are already prescribing methotrexate to your patients and hearing your experiences, I'd love to hear it. Or any general questions, I would be happy to answer those as well.